My name is McKenna Byerly. I'm with the CME office. And like I said, my colleague, Mary Middleton, is also here with us today, and she'll be monitoring the chat. So feel free to chat with us during and questions in the Q&A section. So to go ahead and get started, I'd like to introduce Dr. Doss. He received his medical degree from the University of Cincinnati in Ohio. He completed an internship in general surgery and a residency in neurological surgery at the University of Louisville. Dr. Doss's patient care focus is complex spine surgery and general neurosurgery. And so with that, I would like to introduce Dr. Doss today. And thank you guys for all being with us. And please be patient if we do have any issues with Zoom. As you all know, we're all still learning. So I will bring on Dr. Doss now and turn the program over to him. Thank you. Let us know if you have any questions.
As she said, my name is Kamathi Doss, and I've been a practicing neurosurgeon here in Louisville, Kentucky since 2002. I completed my residency here and then stayed on with Norton Neuroscience, mostly doing spine surgery. I do some general neurosurgery, but a majority of my practice, 95+%, all has to do with spinal procedures and spinal surgeries from cervical down through the lumbar spine. Today's talk, we're really going to be talking mostly about lumbar spine procedures and diagnosis, some anatomy of the lumbar spine, along with treatment modalities and imaging modalities. However, if you happen to have questions regarding any part of the spine, I'm happy to answer those at the end. So we'll get started. We're just going to talk really quickly about some basic anatomy. As far as basic anatomy goes, the lumbar spine is really composed of 6 bony segments. You have 5 lumbar segments and 1 sacral segment. The spinal cord usually ends around the L1, L2 level, so you can get spinal pathology in the lumbar spine if you have upper lumbar spine issues. In the lumbar spine, we really are more focused on the 6 nerve roots that we deal with, and that's going to be the lumbar nerves 1 through 5 and the 1 sacral nerve. And of course, all these components with their small nerve roots form the cauda equina. Now, unlike the cervical spine, when we're trying to identify landmarks in anatomy, when we're evaluating patients, the lumbar nerves come out the level below their vertebrae. So in the cervical spine, the cervical nerves come out above the level. So if you have a C6 nerve problem, or you have pain that goes down to your first and second digits with weakness in your wrist, you're going to look for a problem at the C5-6 level. Whereas if you have a L5 nerve problem and you have pain down the side of your leg and weakness lifting your foot up, you're going to look for a problem more at the L5-S1 level. So that's kind of the one caveat between the lumbar and cervical spine. There's also a lot of muscles, ligaments, and jointing attachments. You have the vertebral bodies, the disc spaces, and the posterior facet joints. And so all of these form our back. Oops. So when we look again at our nerve roots, we like to look at dermatomal patterns. And like the cervical spine, our dermatomal patterns in the lumbar spine form more of a candy cane type pattern around the leg. And that gives us a good idea of where we're going to look for pathology. When we look at our L1 nerve, that usually has to do with hip flexors, and you're going to have symptoms that go into the anterior thigh, more toward the groin area. So you can be fooled by hip pathology with that. The L2 and 3 and 4 nerves all kind of form a pathology that goes more for knee flexion and hip flexion. And when you have sensory problems, again, if you look at it as a candy cane shape, the 2 nerve is going to come up over the anterior medial thigh. The 3 is going to go down medial thigh to about the knee. The 4 nerve can make it all the way down to the medial ankle. And this same pattern works for our sensory patterns of this as well. When we think of stuff for radiculopathy, and we always talk about patient has sciatica. When a patient has sciatica, they actually could have any one of those nerve roots affected because they all form the sciatic nerve before they split and make this candy cane shape down the leg. So an L5 nerve pain could be called sciatica, but the better definition for us, particularly as treating physicians, we prefer an L5 radiculopathy as opposed to sciatica because that does give us some anatomical landmarks on where to look for pathology. So this is just a blown up view, and we really get a good view of how that pattern runs down our legs. We can see how the L1, 2 nerves come more medial superior part of the thigh. The L3 nerve comes down, typically making it to the knee. The L4 nerve can come all the way to the medial malleolus. The L5 nerve comes straight down along the lateral aspect towards that great toe. And the S1, we see more on this backside, going straight down the back of the leg. It'll cover the heel. And then you get some sensory stuff in the small toe. When we look at symptoms based on location, we have a lot of different symptoms that people will get as patients. They can develop back pain, they can develop leg pain, they get numbness and tingling, they can get weakness. When we think of back pain, we're usually thinking about the axial or mechanical back pain. And for that, we can have problems in multiple areas. We can have it skeletal muscle, we can have it in the facet joints, the posterior elements. We can have them in the discs, the ligaments. Again, they can be in the musculature. Causes of back pain can be varying. Sometimes we just wake up with back pain. Sometimes we strain our backs, or we have degenerative changes with time. We start seeing degeneration in patients even in their 20s, but typically we look at that in the 30s or 40s. If we got imaging on everybody over the age of 50, we'd see degenerative changes in 90% of patients, 95% of patients. The one thing we always got to be careful about is when we start looking at radiology reports. Radiologists have to be very detailed, and they'll say they've got degenerative disc disease and they've got stenosis and they have this and that. What we really care about is, do they have compression? Do they have instability? Are their bones slipped out of place? Having a small disc protrusion doesn't necessitate surgery. It may be something that they're just identifying that really has no cause and effect. When we look at our leg pain, again, we're looking at that dermatomal pattern that we talked about earlier. Certain pains will go down the leg in certain dermatomal patterns, and that is what we would call sciatica, or more specifically, radiculopathy. You can have this happen from varying reasons, and this is going to be nerve root compression. We see people with disc herniations. We see people with facet arthropathy and stenosis. We can find synovial cysts in the back. We can have stuff like pseudogout or small lesions, neuromas. So there's a lot of different reasons why we could develop compression of the nerves. When we look at cord problems, which you can get in the lumbar spine, this is kind of the great mimicker. And I always worry about patients that have painless weakness. When you have a cord problem, you can have weakness without pain. And that's one where you really got to be careful about. Looking at some of the different reflexes that we have, both in the upper and lower extremities, help us identify that. But a cord problem can be painless, can be without sensory symptoms, and people can have problems with gait, function. They can have problems with weakness. They can have bowel and bladder problems. If we start seeing things like myelopathy with hyperreflexia, we got to be a little more concerned, maybe a little more diligent and quick about finding things out and see what's going on. Causes of spinal cord compression are similar to that you get the radicular problems with. It's anything that leads to compressive elements on the spinal cord. And again, that cord typically ends at about L1, 2 for almost all patients. So when we look at diagnosing patients with back pain or leg pain or weakness, as usual, we're always going to try to get a history, physical exam. We want that to be very detailed. We're going to get varying kinds of imaging. There's also electrophysiologic studies we can get. We can get nerve conduction studies. We can get motor evoked potentials, sensory evoked potentials. These can all identify specific nerves that are being affected. We can use other modalities of treatment to help us identify where a problem is. If we get a specific block, if you have a patient that you think has L5 leg pain, and you know that it's probably at that level, he matches the symptoms, you can do a diagnostic block, a transforaminal block that just works on that nerve to see if it improves the pain. Now, we do have some distractors that do affect us when it comes to low back issues. The biggest ones are going to be hip problems and SI joint problems. Hip pathology can fool a lot of us. It fools me quite often. A patient will come in and they'll have pain in the hip and groin and complain about excruciating back pain. We do a workup, and again, on a lot of these patients, we're going to find them a little more seasoned. So they're going to have some degenerative changes in their low back, and we kind of insist that it's coming from the low back. And lo and behold, I've even had a patient who had a chronic femur fracture and could not walk, and had been getting images after images on his low back that kept on showing the same problem. So we can get fooled by that. Similarly with the SI joint. So the SI joint is that sacral iliac joint, and we can induce problems with that from surgical problems. We can have problems with that from degenerative problems. But where your sacrum attaches to your pelvis or your iliac bones, and then that attaches to your hip, We do have problems where we get degeneration changes in that joint. That joint does not move, even though we call it a joint. It basically is solid bone. There is some ligament attachments to it, but if you wear through those ligaments, you can get some micromotion, some edema, and that can lead to low back pain, which can radiate into the hip and into the groin area. So I always want to look out for those. So things with the history and physical, we like to look at range of motion, seeing what causes the pain, leaning to the right, leaning to the left, flexibility, specific descriptions of the pain. The pattern of the pain is very important. What part of the leg is it going down? What part of the leg do you have weakness with? The timing of the pain, is it in the morning? Is it nighttime? Is it just on the bottom of your foot when you first wake up in the morning, which can fool you for, plantar fasciitis or other issues? What helps it? What makes it worse? Again, we're going to look at motor function because there are certain nerves that are very easily identified. If you can't lift your foot up or you have a foot drop, it's almost always going to be an L5 problem. If a person can't push on the gas pedal or can't do toe raises, that's going to be an S1 problem. When we start getting more proximal, there's a little more mismatch with the nerves. So knee and hip flexion are going to be 2, 3, and 4 for a majority of it. So it could be any one of those. It's harder to get subtle weakness in those muscles because you got a lot of nerve intervention in those compared to the dorsal and plantar flexion. And then we always want to look at our our reflexes. Things like hyperreflexia, clonus, those all give us an idea of cord problems. A Hoffman's is a reflex in the upper extremities where you flick the finger and the thumb jumps. That gives you an idea of cord compression in the cervical spine, which could cause weakness in the legs. Hoffman's is just simply doing a quick reflex on plantar flexion where you push the foot up and see if it bounces back at you. The other thing are hyperreflexia, so big, brisk reflexes in the patella. Very hard to find brisk reflexes in the Achilles, but in the patella, it is more common to see that if you're going to have hyperreflexia in the lower limbs. So we like to look at different imaging, and imaging modalities make stuff a little more confusing. There's certain images that really are helpful. There's other images that aren't so helpful. We're going to kind of go through a whole lot of them. And then at the end, I'll kind of explain ones that I think are more helpful than others. So when we look at imaging modalities, we have plain films. We'll have myelography, which is injecting contrast into the spinal fluid and then getting x-rays. You can get what's called a CT scan or CT myelography. So a plain CT scan, or you can get a CT scan after you've had a myelogram, which again is injecting radiopaque contrast into the spinal fluid and then getting images. We have MRIs. We also look at radionuclide imaging. And then discography. So when we look at plain films, plain x-rays are really cost effective. They're easy to get. They allow us to identify more so just bony alignment. We can see degenerative changes. Unlike the cervical spine, a little harder to identify foraminal stenosis unless it's real severe, but it does give us an idea about degenerative changes within the disc heights. It also gives us an identification of facet joints. So when we look at this film, we would look at this and say the patient has overall normal lumbar alignment. They do have some degenerative changes. If we look down here, we've got some degenerative changes at the L5-S1 level, which is at the very bottom level down here. We see some degenerative changes at the L4-5 slightly. As we go up, the disc heights get smaller, so I would deem these more normal disc heights. Here's our AP view, so that's looking front to back. And on this one, again, a little harder to tell unless you're used to this. We've got some facet arthropathy, so a little bit of thickened bone off to the sides, but the alignment is otherwise well preserved. This gives you an image of So then when we look at that, we look at, again, what plain x-rays do. They allow us to look at global balance, alignment. They allow us to see if someone's developed a scoliosis or degenerative scoliosis or instability. And again, they look at disc height loss. We can see some osteophytes, bony sclerosis. And then we can sometimes see some malformations, a little more difficult to see. When we look at myelography, this gives us a little better picture than just plain x-rays, but again, this is more invasive. This requires an injection into the back. The white stuff we see inside here is the contrast, and the little stringy things are the nerves that go through there. And so we can outline the nerves, the cord, if we're up high enough, we can outline where the nerves are leaving the spinal canal. And then we can visualize the whole canal in alignment. And so on this picture, what we actually see is we kind of see an anatomical block at the L2-3 level where we have contrast at the number 2, then we lose contrast until we see some at number 3, and then we lose contrast again, and then we see some more contrast at 4. So we would look at this and say, this patient likely has stenosis at L2-3 and L3-4. So a little more informative than plain X-ray. CT scans are nice in the fact that they are quick, inexpensive when it's compared to MRI, and they do give us really good anatomy, bony anatomy as opposed to soft tissue. They're widely available. We can get imaging in multi-planar, so we can get what are called coronal imaging, which is slices from front to back. We can get sagittal imaging, which is slices from side to side. And then we can get axial imaging, which is slices straight through the spine. And we can look at these all at the same time. So you can correlate these to pathology where you see some narrowing. The other thing that's nice about a CT myelogram or CT image is from a CT image, you'll end up with several hundred pictures. Usually in the neighborhood, particularly with myelograms, in the neighborhood of 500 to 700 images. And this happens in about 2 or 3 minutes, as opposed to an MRI where you might get 40 images and it takes you 45 minutes, a little harder to sit still. So again, CT scan is very good at visualizing bone. Does have a little limitations to looking at soft tissue. It's a little harder to identify disc herniations or nerve root compression. And I deem it more of a fancy X-ray. Now, CT myelogram, in my opinion, is probably the most sensitive and specific image we can get of the spine, whether it's cervical, thoracic, or lumbar. And the reason why is, unlike MRI, it does allow us to get massively more images. You could do a CT myelogram of the entire spinal axis in probably 15 or 20 minutes. And with that, you'd end up with all three being in the neighborhood of 1,800 images or 1,800 slices. If you did an MRI of the same length, it would probably take you an hour and a half, 2 hours, and you'd end up with several hundred slices. So it does allow a lot more detail. It also allows you one thing that an MRI does not. You can then get standing flexion extension films to see if there's any difference in alignment or stenosis when people are weight bearing. The catch to doing the CT myelogram is it does require lumbar puncture, so you are actually injecting contrast directly in the spinal fluid. When they do this, they typically do it under fluoroscopy. They do numb up the skin, and the nice part is, unlike epidural injections that you get for pregnancy or other reasons, because you're using imaging or fluoroscopic imaging to get the contrast in the spinal canal, it's much quicker. You don't have to poke a patient 20 or 30 times to get in the space. Usually, this is done by the neuroradiologist or the interventional radiologist, and it's just a single poke go into the spine. Once they get the contrast in there, they put you on a tilt table, allow the contrast to run down the spine, and then they get the CT scans and they get the standing X-rays where they can get the bending and flexion extension X-rays. So this is just a picture of a CT myelogram. And again, it does allow you a lot more detail, and I'll show you the comparisons of that to an MRI. What we can see on the left-hand images, we see the vertebral body. So this would be called a sagittal image. The things sticking out back posteriorly or to the right are the spinous processes. Those are the piece of bone that you feel when you poke yourself in the back. In between those and the weight-bearing bones are numbered L1, 2, 3, 4, 5, and S1. And in between those are going to be the disc spaces. Now, in between that backbone and the front bone is a spinal canal. And if we look at the top part of this, the thick dark going down the middle, that's the spinal cord. And here it ends at 1, 2. And then the little streaks in here are going to be the nerves. The picture on the right is called an axial image and allows us to see the vertebral body, which is on the top of the screen. The bone you poke yourself in the back is on the bottom of the screen. And in between the two, you'll see this gray round spot. And all these little dots are the nerves in there. So on this picture, you don't really see much for pathology, but it does give you an idea what a myelogram looks like. Now we're going to talk a little bit about MRIs. They're excellent at looking at soft tissue. You get good resolution of soft tissue, so you can see things like discs, nerves. You can see stuff that's in and around the bone, but it doesn't give you good detail about the bone. It has, again, it has ability to characterize tissue. You can look for infections, malignancy. You can see stuff, whether it's blood, spinal fluid. It does allow you multiplanar, like the CT images. You do get axial, sagittal, and coronal imaging, so you get the cut through, the side view, and the front view. It's non-invasive, so this does not require you to inject contrast. The other thing that's nice about an MRI is it doesn't require you to get any radiation. So a CT scan is pretty strong radiation. They've gotten much better with CT scans cutting down that rate, and it does not require contrast. When we look at MRIs, we look at two different types of viewing modalities, T1 and T2. The difference between a T1 and T2 image is the T1 image, which is the one on the far left, spinal fluid is dark, epidural fat, and fat is bright white. So a T1 image is very good at looking where the nerves go out. And so on that very far left-hand image over here, we can see the vertebral bodies. We see the sacrum. The dark spot with the white stuff around it is the nerves coming out of these areas. The nice part about this is we can see those and we get good views of those. That doesn't work so good with the T2 imaging, but T2 imaging is very good at looking at problems in the canal. So when we look at the next picture or middle picture, the white stuff is the spinal fluid. The gray things are the stringy nerves. And on this picture, we can see this disc protrusion at the L5-S1 level. The following picture, the far right picture, is an axial image. And what we see on this, we can see where that disc protrusion is coming back dorsally. So it's coming back towards the nerves. On all imaging, whether it's CT or MRI, the left side is on the right side's on the left. So when you go on these scanners, if we look at this picture here, you're laying on your back with your head in the computer screen and your feet coming out towards you. So the right side is over here and the left side is over here on your right side. On this picture, we can see a disc protrusion. We see the S1 nerve root sitting right here, and we can see this disc protrusion pushing into the S1 nerve root. If this patient showed up in the office and said, I have pain down the back of my leg, it's unbearable, I got numbness and tingling in my little toe and sole of my foot, this is where we'd expect to see that problem. Other modalities include something used a lot less frequently, radionuclide imaging. It detects pathophysiologic disturbances in blood flow and bony metabolism. So you can see things like fractures, tumors, infections, anything that causes an inflammatory response. So really bad jointy arthritis could show up positive on a radionuclide imaging. And so what it really does, increased bone turnover or blood supply causes greater concentration of the tracker at that spot. And so when we look at these things, we'll see stuff like this, where we see a bright spot in one of the bones and we say, there's an issue there. So here we would look at this and we can see the sacrum here, the 5, the 4, the 3. So it looks like something at the L2-3 space. It looks like he has something in his elbow. Now down here is bladder, and that's where all this stuff accumulates in. So that's not much of an issue, but that gives you an idea of what we're seeing. There's multiple tracers that are used for this. Finally, we also have discography. Now this is, again, is not something that is as commonly used today. In discography, what you do is you try to correlate an injection into the disc itself with patient's symptoms. So they take a radiopaque dye, they have a patient lay on their side, they then stick needles into that disc base, and they inject contrast in that disc space. When they inject contrast in that disc space, they'll ask the patient, is this mimicking your back pain? It's not meant to look at leg pain, so they're just looking for axial back pain due to discogenic changes. If the patient says, yes, that's where my pain is, and they say no to all the other discs that are injected, then they say, here's where your problem is. And when you do this, you typically have to inject 2 to 3 discs at least in order to use this as a provocative study. There are risks to doing this kind of stuff because you are introducing something in the disc space. My caveat to doing discograms is that if you violate that annulus in any way, that could lead to degenerative changes. So it is kind of controversial to what people are doing. Here is kind of a picture of what's happening. So we see the needles in the L3 disc, the L4 disc, and the L5 disc. And then they get these injections. They ask if how the patient feels after they do the injections, and then they get imaging afterwards. By getting the imaging afterwards, they can see if the tracer leaves the disc space. So if we look at the 4 disc space, it starts moving out of the disc space. So we say that that person has a tear. They have some problems with that disc more so than they do at the L3 and the L5 disc space. And again, if we look at this front view, which is the one on the left, we can see 3 contrast stays in the disc space. The L4 moves across and kind of out the side. The L5 stays in the disc space. So this would correlate to a problem in the L4-5 disc space. And that's just what we're looking at with these symptoms. So that's just what we're pointing at here at the L4 disc space. So one of the problems we start running into with imaging, there's several things. When I look at imaging, the most important image is images that you can actually identify pathology on it. So for me, a CT scan, plain CT scan, is not going to be a very helpful image. It's a little easier to get approved. Patients go to the emergency room and get them done all the time, but they're really not very helpful because they're only going to show us if someone has a pathologic problem. So do they have a fracture? Do they have something eating away bone? And you can see those kind of problems. A problem with it, with a plain CT scan or plain X-ray, is you really don't get a good evaluation of what's causing compression of the nerves, or is there any kind of instability. So a better study is always going to be, in my mind, an MRI or a CT myelogram. Again, a CT myelogram is something that requires contrast injected, so it's a little more invasive. I would reserve CT myelograms for people that have had prior instrumentation or people that have had bad stenosis at multi-levels that are a little harder to tell on MRI. So when we're looking at trying to get approval for imaging, things that help us to get approval, because it is very difficult to get imaging nowadays. It used to be I just write for an MRI and they get an MRI. Nowadays, you have to have documentation in notes in order to get these approvals. And even when you do, you still sometimes have to do a peer-to-peer review. Things that'll help get approvals for imaging: symptoms lasting greater than 6 weeks. And again, you have to document this stuff. Patients have attempted conservative management, whether it's anti-inflammatories, physical therapy, and they would have had to done those in the last 2 months. Any kind of neurologic change is helpful for getting any imaging done immediately, particularly if it's motor, bowel, bladder. Sensory is a little more difficult. And if you see rapid progressing symptoms like myelopathy, those are a little bit easier to get stuff diagnosed, or get imaging approved. But again, on those, you really got to document all this stuff in there. Just writing, getting an MRI because they have back pain, in my experience, almost always fails. Other modalities we help to diagnose, we can use EMG or nerve conduction studies. This allows us to pinpoint pathology on certain nerves. So EMG nerve conduction studies can help diagnose lumbar radiculopathy versus peripheral neuropathy. So it can identify whether a patient has slowing at the level of the spine, or if they have some kind of compressive element, let's say along the fibular head, which can give you a perineal nerve problem, which can mimic a foot drop or an L5 problem. It can give you a tarsal tunnel or something in the ankle. You can correlate these to your imaging. So you get an L5 problem on EMG, you can then look at your MRI and say, well, yeah, you know, the nerve going out at the 5-1 is a problem, or the nerve going by the 4-5 level is a problem. They can also help you identify cord problems and dysfunction, and it can speed or delay timing of those things. So when we look at the most common diagnostic modalities, it's going to be a CT myelogram or MRI are going to be your 2 best choices. Here's the difference between them. Again, a myelogram followed by CT scan is very good at looking at bony pathology. It's very good at looking at congenital versus acquired stenosis. It's much more sensitive at looking at compression on neural elements. The catch with a CT myelogram is it does require the lumbar puncture, and it won't identify problems within the cord. So if you have a problem within the cord that's not increasing the size of the cord, you're not going to see that. You're not going to see cord edema on a CT myelogram. MRIs are less invasive. They're very good at looking at cord problems. You can also look at the nerve roots. But again, when you have more congenital narrowing, it's a little more difficult to see if people have a problem. It does not show ligament or bony issues as much. It doesn't allow you to get dynamic flexion extension films or weight-bearing imaging. And there's certain contraindications to getting an MRI. If they have a pacemaker, if they have certain metals, so if they have old stainless steel metal in their body, it's going to be a problem. If they have a foreign body, a lot of times it's more difficult or contraindicated to get an MRI. So here's the difference between the two, and this is the same patient. One is a CT myelogram, one is an MRI. And on the MRI, you would look at this and say, wow, it looks like this patient has a fracture that is subacute, because we see this white edema in there. He's got some disc bulges at 2-3, disc bulges at 3-4. Again, he has that fracture at the L3 vertebral body. He's got some degenerative changes at L5S1 and bulging on all the levels. But when we look at his tightest level on here, it doesn't look too bad. He's got pretty good room here. Now, when we look at the CT myelogram, we can see that old fracture is actually healed. So he doesn't have an acute fracture. He just has some bony edema in it from some inflammation, but it's not acute. This is a chronic healed fracture. He has basically bone on bone and lost all the disc at the L4-5, L5S1 level. He does have some narrow, and we can see on the bottom right-hand picture, he has some ligamental hypertrophy that actually is pushing on the nerves. You don't really identify it on the MRI over here, but those same slices over here, we can see he's got some lateral recess narrowing of the 5 nerve on the left and the 5 nerve over here on the right. So it does give you a little more detail. Now we're just going to talk about some of the common pathologies that we see in the lumbar spine, since we've gone through all the imaging modalities, kind of the evaluation, motor sensory. Pathologies that are most typical in the lumbar spine are going to be disc herniations. You can have spondylosis or stenosis, and spondylosis is just a fancy term for saying degenerative arthritis. Stenosis can be varying degrees, but all that means is that the canal is smaller, or where the nerve goes out is smaller. You can have mild trauma, such as a lumbar strain. You can have severe trauma where you have more fracture dislocations. When we look at disc herniations, discs are made out of 2 materials. They're made out of an outer annulus fibrosus and an inner nucleus pulposus. When people always say, oh, the inner layer is like a jelly, it's more like a jelly, but this is a very dense jelly. It's not a liquid. This is something that if you go in and reach in and grab, it's going to be a solid material, but it is softer than the outer part. So I think of it more of a outer part that's like the outer part of a car tire that's really dense and hard, and the inner part is more of the rubber, soft part of the tire. And when you get a tear in that outer part, you can have that soft part be exposed out of it. When it's exposed out of that disc, you get a disc herniation that can push on spinal cord, it can push on nerves, and depending on which one it pushes, determines what kind of symptoms a patient has. So when we look at this picture here, we can see here's the disc space on the far left. We see the outer part, which is a brighter white part, is the outer annulus fibrosus, and this inner more red part that fired through there is the nucleus fibrosus, and then this white part here is actual spinal cord. So this is pushing onto the spinal cord on this cadaveric study. Patients with disc herniations usually present with one or more of the following. Typically starts off with back pain. Once the back pain starts, patients will say, I woke up with this, or I did something, felt a pop in my back, got back pain. And then shortly thereafter, they'll start developing the radicular pain. And the radicular pain can go down the arm, it can go down the leg, it can have numbness, tingling, and weakness. You can develop myelopathy from this. Myelopathy, again, could lead to hyperreflexia, certain reflexes like Hoffman's or a clonus is stuff that you can find. You can have problems with gait, bowel, bladder. And then in lumbar spine, obviously, you can have cauda equina, where people lose bladder function, have severe pain, can be in bilateral legs. If that's not addressed immediately, a lot of times people can have persistent incontinence. When we look at non-operative treatment of disc herniations, we're usually looking at typically the lumbar radiculopathy will usually resolve without surgery. So most patients that have back pain, leg pain, given enough time, they'll resolve. About 90% of people with disc herniations don't require surgeries. do physical therapy. They can do bracing for this. Medications. Typically, I start off with things like a steroid pack, an anti-inflammatory, muscle relaxers. A little harder to start passing out narcotic medications because of all the rules regarding that. But typically when patient has acute radicular pain or leg pain, pain medicine doesn't work as well as the steroids or anti-inflammatories. You can also do injections. And again, injections can be both therapeutic and diagnostic. Surgical procedures for disc herniations can be done either anteriorly or posteriorly. When you do an anterior procedure, you can do it with a fusion. You can do it with or without posterior instrumentation. You take out the disc herniation, then you got to put a spacer in there. You can do what's called disc arthroplasty. It's not done as extensively in this country. It's done much more commonly in cervical spines. In the lumbar spine, there's been a lot of complications, and outcomes haven't been as good as what they found out in Europe. So again, it's not done commonly in the United States, but that is an option. You can also deal with disc herniations, which is more typical from a posterior approach. And people will use varying ways. You can do what's called a laminotomy, where you just make a small hole in the posterior elements of the bone. You can do a laminotomy, foraminotomy, where you clean out where the nerve goes, and then you can do a discectomy through all that stuff. You can do what's called a traditional laminectomy, which is removing the entire bone. And that can be done with or without fusion. And this is just a general picture that goes through kind of the disc space and where the nerves are coming out. And this just shows the lumbar nerves coming down through here and how you can have compression from disc, which is off to the side. You can have thickened ligament that's out here. You can have synovial cysts that come through the joint. And all those can push on the nerves. And then you also have pain fibers in the disc that can lead to axial pain. If we look at lumbar degenerative stenosis, this more commonly presents in people 40 years or older. It can be associated with back pain, leg pain. You can have numbness, tingling, weakness. It can come with a history of trauma. So a lot of patients will say, I was lifting something, bending something, doing something, and this is how it started. The most common nerves to be affected from this are going to be the L5, S1 levels. So again, we can identify where we're at based on how it goes down the leg. Treatments for this are similar to the anterior lumbar, posterior lumbar for the disc. We typically start off with changes in activities, bracing. We can work on physical therapy with flexion, with flexibility, strengthening exercises, medications, and again, the same medications, typically injections. Surgery on these ones, we're looking at usually stabilization procedures where we have to decompress and put in screws and rods. We try to save that as a last resort. This is just simple imaging looking at the difference between an anterior lumbar arthroplasty, so an artificial lumbar disc. And this just shows what an artificial lumbar disc looks like. So it does allow for motion. The one on the right shows a anterior lumbar fusion. So we see a cage with screws in place. Not much range of motion is lost by fusing. This is just a general outline of how we decompress. So when we look at doing decompressions, we can do it either a laminotomy or a laminectomy. And this is just showing what the lamina is. So the stuff in pink is more of the lamina, and down in the middle is where the nerves are being compressed. So when you clean this out, if we go to the right picture, we see all the nerves. We use biting instruments called Carrison punches to kind of clean it out. And this is just showing cleaning out where the nerve goes out, the exiting neuroforamina. The difference between an anterior and posterior approach are significant. Anterior approaches tend to be less painful because you do not have to strip muscle off a bone. There's no muscle on the anterior lumbar spine. You have psoas muscle that's out to the side. It does require going through the abdomen, so there are risks to intra-abdominal contents, bowel, bladder, kidneys, ureter, etc. Posterior approaches are typically more painful, take a little longer to recover, and that has mostly to do with the amount of muscle that's stripped off. Things to expect from surgery. Anterior lumbar, they're usually in the hospital a day or two. You got anterior lumbar pain, slow bowel motility, and usually returning to work 3 weeks to 3 months. Posterior lumbar fusions are used in the hospital 2 to 3 days. If you're doing a fusion, outpatient if you're just doing a decompression. Have a little more postoperative back pain, and depending on what you do, if you do a fusion, you're typically going to be out 3 months. The risks of these are going to be relatively the same, with the exception of the anterior lumbar having risk to all that intra-abdominal contents. And that's just kind of what this is showing. So the biggest risks are going to be to bowel, bladders, kidneys, ureters, vasculature, which is probably the biggest risk to big vessels. I tend to use a vascular surgeon for approach. So if a vessel is injured, he can fix that right there, because the amount of blood loss you can lose on these is pretty high. That risk is still immensely low. The biggest risk on both of them is actually going to be infection, and that risk still is low at 3 to 5%. Going through all that, the last couple of things, I'm just going to show a few case reports. And these are just going to be an example of what people will come in with and how the pictures look. So this is just discussing a 68-year-old young lady who had back pain and bilateral leg pain. And on this picture, if we look at the imaging, the middle top image here shows a problem at the L4-5 level where the bone is slipped forward. We can see that in axial view, so a cross-sectional view, we can see that it's tight in there. And we can see on the far right side how the bone slips forward when she stands. So the slip actually progresses when she's upstanding. And so on this patient, she had pain and an L5 distribution that went down the legs. Cleaning this out required screws and rods because of that instability. This shows another similar patient who's had really bad facet arthritis and has a slip. So when we're looking at this, he has what are called synovial cysts that have grown out of the joints. And so we see big fluid collections in the joints, posteriorly in that middle film. We can see on the far right film how the bone slipped forward, and now he has basically bone contacting bone. And then the far right image shows the central canal narrowing secondary to that slip. So on this patient, went in and put in screws, rods, and did what's called a T-lift, where a cage goes in between the vertebral bodies, pries it open, and allows us to pull the spine back into alignment. Here's another patient with a similar slip, but this one is much worse. This is a young lady that basically cut off her entire spinal canal, came in with symptoms of cauda equina, and we see a big compression of the central canal. So we cleaned that out and then basically pulled her back in alignment with some cages and screws and rods. And then we can have some more complex patients. So this is a patient that you'd really want to get a CT myelogram. He has multiple levels of pathology, and it's really hard on MRI to tell how stenotic this patient was. So with a CT myelogram, we can see that he has complete blocks at 3-4. He has retrolithosis at 4-5 and 5-1, and basically bone on all three levels. So this is a patient that we went in and basically reproduced his lordosis to improve it. We can see that on the far right image, and then stabilized it with screws and rods. And this is a patient that had prior surgery. And so we'll see a lot of people that will have prior surgery. They start getting some instability. We start seeing more modic end plate changes, so edema in the bone, and we start seeing slips and repeat disc herniations. And on this patient, we try to restore disc height and alignment, and you got to stabilize these. And that's what we show on the last two pictures. Far right picture, here's a side view where we have the spacers, pried the bone apart, and then basically held it back together. I think I have one. Let's see if I can find one that's. So this is a person that had bad problems both in the front and back. She had prior surgical decompression done years ago, and she has what's called a pars defect. And that's where the bone you feel when you poke yourself in the back is not attached to the weight-bearing bone. And we can see this crack that goes through there, and that's at the 4-5. She also had one at the 5-1 level, and then she basically wore her entire disc space out at the 3-4 level. When we see people with this kind of pathology, they don't have a lot of posterior elements that we can fuse. So on this patient, she actually got what's called a front and back. So went in the front and put in big cages, pried it back open at 4-5 and 5-1, held them together with screws, and then cleaned everything out from the back and held that together, and then improved her overall lordosis and alignment. I'm not sure if we have time for more.
We have a little bit of time left.
Okay.
If you want to keep going.
Yep. So, and then again, these are just going through case examples of different things that we see. So here's another person with a slip, and this slip, they actually weren't too bad when they laid down, but when they stood up, and this is where x-rays can be very helpful. When you stand up and weight bear, so they only had about a 4-millimeter slip when they would lay down on the MRI, but when they stood up, that turned into a 14-millimeter slip. And we can see on this middle picture, here's the back edge of 5 right here. Here's the back edge of 4. So that distance is about 12 to 14 millimeters. The canal diameter in the spine is usually around 12 to 15 millimeters. So if you have a slip like that, you're talking about a complete block, and that can lead to neurogenic claudication. So a patient that has diffuse lower extremity pain, every time they stand up and walk, it kills them. When they sit down and lean forward, it feels pretty good, but they just can't stand and walk. And on these kind of patients, again, that usually requires cleaning things out, pulling it back into alignment and holding it together. The far left picture shows how bad that slip is when they stand. And again, here's the distance. When we fuse it, here's them standing, and we can see that now the slip might be a millimeter or two. And then this is a back view where the cage, and we can see the screws and rods in place. This is a patient that had a large synovial cyst with pars defects. So the bone in the back not touching to the front bone. And right here is where we see that cyst sitting in the canal. And here you clean out the cyst and you got to hold this together. So we do the same kind of procedures there. And this is one who had an epidural mass. So basically had on this one, had a pathology or a metastatic lesion in the vertebral body at L3, and then it basically grew into the canal. And so we can see the canal stenosis. Here's the nerves here, just a little bit of nerve and white stuff, spinal fluid here. This should all be filled with the white stuff. And what this picture shows is cut out that 3 vertebral body and then had to hold stuff together. We've done one like this. I have one in here. We see this a lot, and here too is where a myelogram is real helpful. This is a patient that had multiple prior lumbar procedures done. The first 2 were done with these old cages back here. Then they had another surgery where this cage was implanted, and then they started developing problems above that. And so cleaning this one out, we had to restore alignment. So you can see how they tilt forward. And on our middle picture, we pulled them back and basically reattach it to the prior hardware without taking out all the old hardware. And this is a patient that I wanted to get to. This is a patient that had a disc herniation at one point in time, then had this large recurrent disc herniation. And once we start doing procedures on patients multiple times, we start running into problems where they destabilize. And so they rotate more and they can force more disc material out of their disc space. And this just shows a huge recurrent disc herniation that actually funneled up all the way back almost into the muscle. And we can see that on this axial image. So on this axial image, this is all disc material right here. Here's the top of her canal. Here's her paraspinal muscles back here. And so that shot all the way up into the paraspinal muscles. In order to get that cleaned out and held together and try to prevent this, we end up having to fuse this. So we put in screws, rods, cages, get it back in alignment, take out the disc material. And this just shows what a fusion looks like. You get solid bone across the facet joints, and then the stabilization prevents her from having reherniation. And we'll end with this one. This just shows a patient who had a prior surgery that didn't heal, and then it shows an anatomical block. So didn't heal here. We can see gaps and a crack in the bone. Didn't heal at the 5-1 level, but then has an anatomical block where contrast did not make it past 2-3 or 3-4. So had a slip at 2-3, had horrible stenosis at 3-4, and basically revised the bottom levels by putting in screws and rods, and then redid the 2-3 and 3-4 and clean that out and then hold that together. So these are surgical options to lumbar pathology. And similarly, the same things can be applied to the thoracic and cervical spine and the same modalities. So things that we always want to think of are, where's the patient's problems? Are they sensory? Are they motor? Are they only motor? The great mimicker and the one to really deal with are people that have painless weakness. When people have painless weakness, we really got to be concerned that it's a cord problem. And when they are weak in their lower limbs without pain, focusing on lumbar imaging sometimes isn't enough. And so really getting an exam and finding out if they're myelopathic, if they have Hoffman's or brisk reflexes, or have subtle weakness in their upper extremities, or difficulties with gait, balance, fine motor skills, may actually force us to get stuff faster and get stuff in the cervical and thoracic spine. That's about it. Had to go through a lot quick. Questions?
All right, thank you. We had 2 questions from our participants. So the first one is from Jean Bond, and she says, is chiropractic a reasonable referral for some patients?
Yes. There are some things that chiropractic treatment is good for. In my humble opinion, you can do chiropractic treatment on the lumbar spine pretty much without any imaging. I would be much more concerned about the cervical spine, the thoracic spine, because of the rib cage, it doesn't move much. So you can do some treatments there. On the cervical spine, I'd always recommend people get some form of advanced imaging. Plain x-rays probably aren't enough. A CT scan, I'd still question. Getting an MRI is probably a better thing if people have problems with their neck that they do chiropractic manipulation. Chiropractors do really good work, and there's a lot of things that they do that aren't manipulation. So there's always a possibility, but the one thing I would stress is not to really jump down the road of getting manipulated in your cervical or thoracic spine without formal imaging.
Okay, thank you. The next one is from Kelsey. Regarding surgery for disc decompression, is there a high success rate? Do you suggest this for your patients, or do you try to avoid them getting surgery for the risk of making it worse?
I tend to be very conservative. So I use surgery as a last resort. So I will always start with medications, physical therapy, rest, changes in activities. You can do chiropractic, hydrotherapy, injections. People that have radiculopathy, even if they have bad joints, if their biggest complaint is leg pain, I would tend to be less aggressive than a lot of surgeons. And I would say, just get it cleaned out and help your leg pain. Don't put in screws and rods. The goal is to avoid screws and rods. When you start making people rigid, you always risk causing problems or putting a load on the adjacent level that leads to more surgeries. When you focus on a unilateral side with particularly a leg pain or an arm pain, doing those kind of things tends to be less invasive, a quicker recovery time frame. And therefore, doing those are very reasonable things to do. Certain people, like the images that I showed earlier, getting fusions helps a lot. Fusions work very well with axial back pain, particularly if they notice big differences when they flex and bend. If you are uncomfortable and have horrible pain, and you've tried everything else, and you have pathology that matches that pain, I would have the surgery. I would improve the quality of my life, but I would match my images to the pathology. I would not treat somebody because they had pain. I'd treat somebody because they had pain. They had it in a certain pattern that matched their images or their nerve conduction studies. I would not do stuff because, they got pain down the back of their leg, but they got a disc on the contralateral side at L3-4. That's not a reason to operate.
Okay, just a couple more since we have about 3 minutes left. What are the reasons you would want providers to refer a patient to you as soon as possible versus after trying conservative treatment?
If they have signs of myelopathy would be my biggest thing. So if you had a patient that comes in and their complaint is their legs aren't working, they're stumbling, but they don't have pain, I would be really concerned that they have something pushing on their cord, whether it's down towards the lumbar spine, the cervical spine. So anybody that's myelopathic, someone that has a Hoffman's, has clonus, has Briss reflexes, anytime you have those kind of problems, that's something that I think needs to be seen right away. Obviously, if someone has incontinence, I would send them straight to the emergency room, But people that are myelopathic, I would say absolutely. People that have had medications, that have known pathology, that have weakness, those are people we would see sooner rather than later. For me personally, I can look at a film almost any time. So if there's ways to get films over or get names over, it's very easy to look at a film and sit there and tell you, yeah, this is a problem or this is not a problem. So I've always told people, if you need something looked at right away, there's ways to look at stuff. Nowadays, we can share imaging so much easier. It used to be just a struggle, but now, I get images from Carrollton, like in 2 minutes. You just call up there and they put it on our system. So those would be the people that are myelopathic would be the ones that are really concerning.
Okay. What medications do you recommend for acute back pain and acute nerve pain?
Typically, it's going to be a Medrol dose pack and an anti-inflammatory. If I'm going to recommend medications, topicals, they're kind of hit or miss. They are good for people that can't take NSAIDs for renal issues, but I would start off with a steroid pack and anti-inflammatories. You can do muscle relaxers too, but when you got acute pain and pain in the leg along with the back, the steroids are probably going to work the best.
Okay. Do you always recommend therapy before injections if a patient is having radicular pain?
Not always. And here's the reason why. some people's pain is so bad, they wouldn't be able to participate in physical therapy. And you can kind of get that impression when they come in the office. There's some people that doing physical therapy is just not going to be a reasonable thing. I mean, they just, you know, we have to work, we have to do these things. Physical therapy is going to require you go in there a couple of times a week for several months. So there's certain people that you would recommend a injection for before physical therapy. And there's some people that just, you know, I tend to give people more of the choice. Injections are nice because you get the injection, either you're better the next day or you're not. Physical therapy is going to take some time.
Okay, and then last question, we have 1 minute left. So when do providers order MRI with contrast versus without contrast?
If a patient has had prior lumbar decompression or prior anything done posteriorly, you're going to want to get it with and without contrast. So if they've had prior surgeries done posteriorly in the spine, so anything anterior, you don't have to get contrast, but posteriorly, you need to get contrast because when you go posteriorly, you will have scar that makes it all the way down to the nerve, and you can be fooled by what is scar and what is recurrent disc herniation. When you do stuff anteriorly, you're not going around the dorsal part of the nerve, so you don't get scar on that posterior aspect. So contrast with people that have had prior surgery done posteriorly. Would I get a contrasted image with someone that's had multi-level lumbar fusion? The answer is no, I'd get a myelogram. So if they've had a lot of hardware in them, a myelogram is going to be a better study.
Okay, well, that's all we have. I appreciate your time today. Thank you for being with us.
Not a problem.
Thank you so much. We appreciate it.
All right, y'all have a great day.
You too. Thank you.